waiting for this mic to go on.
Is this mic on? Can you hear me?
In the meantime, let's see how quiet we can get this. Ready? 1, 2, 3, and. Any keys to drop? Bye.
Right, that works. That works. Thank you. We're going to be starting shortly, so if you can take your seats, please, that would be great. We've relocated down here, so if you can't see or you want to move your chair, please do, because the risk assessment gave Jess a heart attack using the ramp. So we're not going to use the ramp, and we're all going to be down here. So I hope you'll be able to see everybody. That sound's not right. Okay, can you hear me? Okay, we're going to be starting any minute now. Are you all comfortable where you're sitting? Can you see everybody down here on the floor? Great. Okay, we may need to shut the doors at the back because it's going to be a bit noisy. Is that on? That one. Okay. So thank you, and thank you for coming back so swiftly and sitting down where you are. That's wonderful. Just to say, I have been kind of in the honor position to be able to introduce quite a lot of remarkable speakers to this platform over the years. But I don't think I've ever felt quite so privileged to introduce you to the next incredible panel. Having heard their stories and what they're going to tell you and share with you right now, I have no doubt that you're going to feel equally as humbled once you've heard what they have to say. Now, technically, I don't have to introduce everybody individually because they're going to be introducing themselves. And they will start with the AV any minute now. Fantastic. And we're going to start with Norm.
Hi, I'm Norman McCarthy, diagnosed with ALS 10 years ago. I worked my entire career in international development, supporting local organizations. I learned from them how to face the odds and how to fight for their rights. So I've been prepared for this fight. I've taken part in 5 clinical trials, and I know the mindset needed to survive and thrive. I joined the ALS Quebec board 9 years ago and joined shortly thereafter on the National Advocacy Committee with the ALS Canada. I'm also a member of the PCOC of the International Alliance. I gave a TED Talk in 2019, got my book published shortly thereafter, and still find the time to travel to various locations with my wife. Most of all, I've had the privilege to see all of my children graduate and to welcome my first grandson and my first granddaughter, because for me, it's all about hope.
Hi, I'm Leanne. I've travelled here all the way from Brisbane, Australia, an accomplishment I could never have achieved without incredible dedication from my allied health team. Back in 2017, I was a fit and active personal trainer, group exercise instructor, coach and professional speaker who had spent more than 30 years in the fitness and wellbeing industry. My world was turned upside down when at the age of 53, I was diagnosed with ALS. Since then, I've worked tirelessly to make sure ALS doesn't stop me from living an awesome life. Just being here in Montreal this week is proof of my resilience and determination. Preparing for this trip has been a long 6 months in the making, and it's all thanks to the incredibly skilled team I've built around me. Together, we developed a personalised rehab program which included intense breathwork training to improve my lung capacity and pass the altitude test to fly, speech therapy, and a head, neck, and jaw specialist to tackle the muscle tightening with the use of tools and exercises which aim to maintain effective breathing and swallowing, as well as adopting a tailored physiotherapy program to support me throughout the ultra long haul flights. Believe me, it really has taken a village. My being here today highlights why it's so important for those of us living with ALS to build the right team. A team that is on the same page, dedicated to the same goals, and has the utmost commitment and belief in the capacity of their clients to achieve the things so many people think wouldn't be possible. I know my life with ALS would look very different without my allied health team working together. I am forever grateful for their expertise. It has enabled me to achieve things beyond anything I'd ever imagined. Thank you.
Hello, my name is Stacy Lewis Farmer. I live in the United States in the greater Philadelphia area in southern New Jersey. I was diagnosed in February of 2021 with sporadic limb onset ALS. My wonderful husband and 2 adult sons are my greatest champions. Prior to my diagnosis, I worked for over 20 years as an obstetric anesthesiologist, a profession I truly loved and miss every single day. When I got my diagnosis, I was completely overwhelmed. And I know how to navigate the medical system. I could not imagine how patients without my background must feel. Completely lost. I did not want my diagnosis to be for nothing. I wanted to use my experience as a physician and a patient to help change the landscape of ALS. My multidisciplinary team at the Temple Center for Hope recognized this and immediately jumped into action to get me involved in many activities. Through them, I became a NEALS ambassador. They got me involved in the congressionally directed medical research program as a consumer reviewer. And through the wonderful Sarah Feldman, my physical therapist at the Center for Hope, I am here with the Alliance. I'm so happy to be a part of this battle. Thank you.
Hello, my name is Leah Stavenhagen, and I'm 31 years old. I was diagnosed with ALS in 2019, and at the time I was just 26. Since my diagnosis, I've become pretty involved in advocacy. I started a group called Her ALS Story. Today we're over 120 women located globally, all diagnosed before age 35. It's a very special network Then we come together to both find community, and also to help raise awareness for better treatments. Today I wanted to share a story with you about something that happened about 6 months ago. So for context, at the time my ALS looked very much like it does today. That means I was in a wheelchair, using a breathing machine. My arms were there simply for show. So I was at an ALS event. There was an event to raise money for research. Then there were some researchers there. After a glass of champagne or two, someone came up and introduced himself. He was a researcher who'd been in the field for years and years. He said, "Let me guess what's going on with you. Do you have a spinal cord injury?" Then I looked at him, waiting for his face to change to say that, he was joking, because obviously I had ALS. He wasn't. He was totally serious. So I'm saying this, I'm sharing with this with you today to say how important it is for people working in the field to recognize the incredible heterogeneity of this disease. ALS could look like me, but it could also look like Stacy or like Paula or like Leanne, but it's so different. And the symptoms manifest very uniquely for each individual. I hope that as clinicians and as researchers, they're able to take this type of information into consideration. I hope that the clinical trials to be designed to incorporate the complexity, the uniqueness of each individual's ALS, and that as also in the clinic, that when patients go, they're able to receive care that is optimized for the way that their disease is progressing.
Hello, my name is Paula Trafiak, and I am from Regina, Saskatchewan, which is located on the Canadian prairies. Try to say Saskatchewan 5 times fast. I grew up with the knowledge that ALS is how we grow old in my family. There's not a single moment in my life when somebody in my family hasn't been affected by the disease. I have been a caregiver for my great aunts, my cousins, my father, and now I have ALS. I started showing signs and symptoms at the age of, could have been earlier, but I knew my signs and symptoms were definitely ALS before I turned 28 years old. And at the time, I was pregnant with baby number 2. Very scary time. It would take a number of years before I was able to get diagnosed. I was finally diagnosed in 2016 at the age of 34. And at the time, we didn't have a neurologist in the province. We didn't have a multidisciplinary clinic. I had to travel to get answers. I was very, very lucky later on that year to have been called to start participating in a clinical trial for a drug offering an open label extension. And that was the VALOR trial. Long story short, I was able to start receiving this drug, and on the open label extension, in March 2019, I started to receive the 100 milligram dose of what we now call tofersen. And within the first 6 to 9 months, I started to see improvement. Now, when I started the 100 milligram dose, I had issues with some lip droop on this side. My ankles were frequently giving out on me. My hands were weak. I was throwing tools around, threw a few knives around. My husband didn't appreciate it. He didn't let me cook anymore. And within 6 to 9 months, I started to see improvements. My ankles weren't giving out on me. My fasciculations and my cramping weren't as bad anymore. In fact, my husband couldn't feel them in bed next to me. That was great. I started feeling better. I started going to the gym. Next thing I knew, I regained 6% muscle mass. I could wear my heels again, which I'm wearing today. 5 years later, I have maintained a lot of this reversal, which is absolutely fabulous. And I don't know how long this is going to last, let's face it. But I'm here using every single moment I have to advocate for people with ALS, to advocate for my children and the next generation, and doing as much as I can while I can.
So I'd like to thank you very much for all of your introductions and some of your important messages. You've been kind of tasked today about spreading the word and sharing your thoughts about how we can do things better. I'm going to ask you last to give you time to write on your iPad, but my question really is about the message you're sharing now, and why is it so important for you to be able to tell this room full of fantastic people what you want them to hear. Now, Norm, you have a slide. I wonder if you'll be able to put Norman's slide up, please, because I'll ask you to start first.
To explain, I was diagnosed in December, and I spent all that month talking with family, traveling, researching ALS, and getting answers. And in January, I went to neuro for a second opinion. And I remember Dr. Getch told me, we have an interdisciplinary clinic, and we could potentially help you live better and potentially longer. And I remember she told me, I have patients who've been living with ALS for 10, maybe 20 years. And that's all the message I need to hear from her. Hope.
Great. Thank you so much. And I think I have to also... You've got more.
Quickly, go back. We all know the benefits of holistic care, one-stop shopping. You know, we also have at the clinic complementarity with private government services. So Kate is at every clinic talking about the ALS Society. Also, their coordination with the Rehabilitation Center to try adaptive aid. Access to global trials is key. And the one thing we don't mention is the importance of Rita. Rita, who is the office coordinator. There's so much paperwork to do with the ALS. And I don't think we value Rita enough. Finally made it my parachute. The ideas for improvement, we can always provide better psychological support. Ideally, there would be osteopathy and chiropractic care as well. And pain management could be better integrated. And I can see. Also, empathy is complex, we give you a guide we'll never read, but so you, as healthcare professionals, need to remind patients of the next step. Knowledge of alternative treatments, at least informing them of ALS Untangled and how to dose and use cannabis properly. And finally, for researchers, I met researchers who never met an ALS patient. That's very important. And finally, one final suggestion is maybe do an annual review with patients at every clinic. Thank you.
Thank you. But there's some very important messages, and I think we've talked about pain management a few times, and I think it's something we need to, as you say, work very hard on to improve. Stacey, may I ask you what it was and why, what was so important in your message? Why did you want to share that?
Thank you. As I progress, the disconnect between who I am in my head and who I am on the outside grows larger and larger. My wonderful multidisciplinary team, the ALS Hope Clinic, I'm not being paid to say this either, even though they're all here. I realize this. They're helping me to mitigate that disparity, which is so important to me. Not only the things I mentioned in my video, but I'm involved in also observational studies, such as brain-computer interface. I'm involved with playing the gala, I partake in their walks, so much more. It is an understatement to say that the ALS treating community has no easy task. The heterogeneity of the presentation of ALS, each patient presents differently, makes it so challenging. However, there is also heterogeneity in how we react to our diagnosis. And that is huge and equally important. Whether you want a pen or a drink or you don't want it, even if you want or don't want a wheelchair, these things have to be recognized. So my ask is this: please educate your patients so they can make the best decisions of what they believe their quality of life is. No one can tell you what quality of life is but yourself. And when they make that clear, help them find the resource if you cannot supply the opportunities themselves. Thank you.
Stacey, thank you for your insights. I think it's so valuable because there are very few people who have been on both sides of the healthcare and using the system. So your insight is incredible. Thank you. Paula, may I ask you what is so important? Why is it the message you're giving? What is that? What's the reason for that?
I was in a really unique situation when I was diagnosed with ALS. I had my care providers telling me, why bother get diagnosed? Why bother? Because there was nothing they could do for me, is what they literally told me. There's no cure, there's no treatment, so why bother knowing this? It's better just to keep going on your way. But I'm thankful I did pursue genetic testing, and I also pursued testing to see, whether or not I was symptomatic. And the reason why it mattered was because I was now on a list of people who had my variation. My genetics counselor had that. And when somebody called from the neuro to my genetics counselor saying, hey, do you know anybody with this gene? We now have a treatment. My genetics counselor was able to say, yes, I know some people, or I know this person. And that they contact me, hey, we now have a treatment for you. It's in a clinical trial, but it's worth a shot. Do you want to participate? I said yes. And if I hadn't been tested, if I had not followed that advice, I would be dead by now. I wouldn't have survived this long. So I think as care providers, researchers, we need to be working with people, working with families. And even though they're, especially, those C9 people, we may not have a treatment, but we will soon. We need a registry, even if people get tested and they can keep their results locked until they're ready. When they all of a sudden hear, oh yeah, there is something, and at least have that choice to participate later on. But those discussions need to start happening now. And I mean, it takes people some time to come to terms with the decision to get tested. That is heavy, I get it. But those, like I said, conversations need to start happening now so that, when there is something available, we're ready.
Thank you. Thank you very much for sharing that. And that's a very powerful message that we heard this morning and throughout the day about the power of research and giving people the opportunity to take part in it. So thank you. Lee, could you explain to us, you shared the story of the researcher. Why was that so very vital for you to tell us about that?
So I think something that I should have mentioned is that when the researcher explained that he was trying out a spinal cord injury, and I said, no, it's ALS. He said, no, that's not possible. You're a young woman. And we know very well that that's not true. I'm in a group with over 100 young women diagnosed before age 35, and I thought, this is a bad situation to be in because here's someone who's dedicated his life to trying to find a better treatments, to find a cure, but he's not taking the full patient population into consideration. That I want to make sure that the research is being designed in such a way that we're not forgetting huge portions of the population. Of course, we're not going to find something that works for everyone, but everyone should be considered. And then maybe a second part of that is that when we go into clinic, I want all professionals to be considering the person in front of them, right? That individuality that others up here have mentioned. What I want from my physical therapist might not be the same as somebody else. My struggles as a 26, 27-year-old, no longer being able to work properly, I was really concerned about finding huge shoes. That might not be the same if it were my father that had been diagnosed. So I think that's super important to consider as well.
Great, thank you. I think that's a really important message for us to all kind of take on board and digest. Thank you. Leanne, are you okay to share your...
Thanks. Substituting now for Leanne. Okay, here we go. I just say listen to your clients and find out what makes them tick. Find their purpose. I love travel and I was determined to get here no matter what. Everybody from the neurologist to the dietitian to the respiratory, it's a tough word for me, the respiratory doctor, and you name it, friends, relatives said, don't go, it's a big risk. But listen to what the patients say because it's their, this is Leanne's purpose. Did I do all right?
And
Oh,
there's more.
Oh, here it comes. Sorry.
Yes.
Amen. There's nothing else after amen.
And I have to say, I think from yesterday and today, I think everybody's very delighted that you ignored everybody's advice and you worked hard to get here to be with us today. Now, I'm looking at Jess about time. Do we have time for one question? We have time for one question and maybe to an individual, but I don't think we're going to be able to each and everybody answer the question, but is there any questions in the audience? You've left everybody completely dumbstruck. Or any comments, maybe? There's a comment at the back. We're very happy with that comment. Any other comments, you're very welcome. So I think, thank you for that. That's incredible. I think what we'll do is we will leave it that as it is, but I have to thank you on behalf of all of us for valuable insights, lessons that we're really going to take home and really very much think about. So thank you so much. What we're going to do now is we're going to have a 5-minute pause, don't move, while we all move, we move the lights, move people, and rearrange ourselves. But we'll just be back in 5 minutes. But thank you once again.
Sure, I think so.
Okay, are you ready to make another start? Are you sitting comfortably? Okay, we're going to make a start, and I'd like to welcome Catherine Burke to the stage. She wanted to come this side to be with her people, so make a noise. Come up here. So Catherine is going to be talking about harnessing digital health techniques to quantify limb function activity in ALS.
All right. Thank you so much for having me. And I turned to my table and I said, why do I have to be the one to follow that panel? But I think it is quite a privilege to be that person, and I'm very happy to be here. And thank you for all patients and caregivers. You remind us every day of why we're doing what we do. So without further ado, I'm going to share some of the work that we've been doing on using digital health technologies to quantify limb function and activity in ALS. I personally do not have any conflicts of interest to report, but some of the work presented today was funded by Biogen and MT Pharma. So, quick objectives. I'll go through the background, how we've been using digital health technologies, some of the lessons learned, and then some considerations that we have related to using digital health technologies. I wanted to start off just by making sure we're all on the same page when we talk about digital health technologies, and the FDA defines them as systems that use software, sensors, computing platforms, and connectivity for healthcare. Okay. And for the purposes of this presentation, I'm going to focus really on smartphones and wearable sensors, both of which can capture active and passive data. And when I talk about active data, that could be surveys that people are completing for us, or if they're doing a specific task or an exercise with either the smartphone on them or with the wearable on. And passive data is where we just ask that they have the device on them, and then we're collecting information from the GPS, the accelerometer, gyroscope about different movements or activity patterns. So, why did we start using digital health technologies? I think most of us in this room probably know that there is room for improvement in our measurement in ALS, and our traditional measures, like the ALS-FRSR revised, vital capacity, handheld dynamometry, well, they have their benefits. They also have limitations, and some of which they're not always sensitive enough to capture changes that patients are telling us are meaningful. They often rely on in-person visits and consistency with evaluators, which is not always possible. And so what do we end up with? Well, we have a lot of negative clinical trials. And is this because the therapies aren't actually working? Or is it because our measurement tools aren't able to capture the meaningful changes during that study duration? And so in order to answer that question, we need to make sure that we have really robust outcome measures. I would also argue that there are impacts on clinical care, and at least in the US, if someone needs a communication device or a power wheelchair, insurance really doesn't cover it until they need it, which is too late because then it takes several months to get that equipment for them. And my hope is that if we have more robust outcome measures that can very accurately predict when someone might need that equipment, then we might have a better chance of convincing insurance companies to approve them earlier. We're not there. I hope that's where we're headed. So the kind of low-hanging fruit when thinking about digital outcome measures really was surveys. You can put surveys on a smartphone and administer them really as frequently as you want and as frequently as participants are willing to complete them. And so in the next few slides, I'll just show examples with the ALS-FRSR where we have done this, And this first one is a 24-week study, weekly collection of the ALS-FRSR on a smartphone app. That's the BWE app. And then staff-administered traditional collection of the scale at every 6 weeks. And on the x-axis here, you have the patient-reported FRS scores. The y is the in-person. And while it's not a perfect correlation, that gray line would be that perfect correlation, it's very close. So this was 0.93. And the shift of that red line to the right of the gray shows that our patients do rate themselves higher than we do. This has been repeated a few times. This was another study. We looked at 3 different time points and saw the exact same thing. This time, the y-axis has the self-reported, which is why you see the blue lines on the other side of that dotted line. But again, very high correlations, and patients are slightly rating themselves higher than what we get with a staff-administered. One more example, this was a 25-week study, again with the weekly administration, and then the staff-administered this time was every 12 weeks, and we see the exact same thing. So it is very reliable way of collecting at least the FRS, and it can be done with really any other questionnaire. We did take that last study one step further to see, well, what are we gaining from this increased frequency? And so what you're seeing here are panels of the total FRS score and then each of the subdomains, fine motor, gross motor, bulbar, and respiratory, and the estimated monthly change. And what we see is that, I guess, let me go back a step. In each panel, you see the traditional staff-administered FRS collected every 3 months, the digital, if we were to collect it every 3 months, and then the digital at monthly every 2 weeks and weekly. And while the point estimates don't change, it's those confidence intervals that do come down, which increases the accuracy of our estimates and can make for higher powered studies or more efficient trials. I will note here that at least for this study with this group of participants, the 2-week to the 1 week wasn't much different. So we maybe don't need to be asking them to do it as often as we are. So then we wanted to take it beyond surveys, and what else can we get? And this is smartphone data quantifying activity levels. And here, what you see along the x-axis are different participants. Those are individual participants, and on the left, we have their home time, and that's their time spent at home, collected by the GPS data, and then distance traveled from their home. This data represents the first month after they completed the self-reported FRS, and it's their median score with those interquartile range. So we can see here that we are able to collect and quantify how much time people are spending at home and how often and how far they're traveling from their homes, which may have implications for social connectedness and possibly loneliness or isolation. We are starting to look at that more to see if this is actually meaningful. Another representation just to show how much we can capture these behavioral changes. This was actually 8 people who were using the BWE app at the time of the COVID lockdowns, and we looked at their GPS data for 1 month prior and then 1 month after the lockdown, and you can see those very expected changes where our patients went from spending quite a bit of time at home to almost all of their time at home, and their distance traveled decreased significantly. That line that you see in the middle is the US state of emergency when it was declared. So the GPS data can capture these behavioral changes. This is just a very stark example. So what about walking? Can we get information from the smartphone about walking cadence or different gait metrics? And in this, it's the same study as 2 slides ago. Again, you have the participants along the x-axis, and now we're looking at cadence. The cadence on the left, and then the walking cadence from their top minute in each day on the right. And again, it is the median from that first month and the interquartile range. And you can see that, yes, we can capture some information about walking from smartphone. But do these change over time? We can capture the data. Can we capture changes over time? And so from that same study, we picked 8 metrics to look at. 3 of these did meet significance when looking at monthly change over time. 1 was trending, and that's the walking cadence from the top minute. The 3 that were changing were the activity index and then the step counts, both from their daily step counts and that top minute. And then the next step that we wanted to look at was, can we capture changes in limb movement? So this study, we had participants who were wearing an Actigraph watch on one of their upper extremities, and we were capturing different movements of that extremity. So the C on the y-axis for each of these are their counts of movements. The F are what we called flexions. That was any time the arm was elevating. The E were the extensions, or any time that arm or the watch was coming down. And then the S and the P are your supination, pronations, or the rotation of the forearm collected by that device. And we see that over 6 months, these counts were coming down. Each of the colored lines represent a different person in this study, and then you have the average across. So we can capture changes in the extremity. We also looked at the duration of those movements. So while the number of counts are coming down, they were also taking longer, which is what we all, I think, clinically see happening, but this gives us a way of quantifying it. And then this image to me is quite striking. This is one individual's raw data from that same study, and looking at day 1 up to day 141. Each gray dot is a single point of when movement was collected, and then the lines represent when there was more than 90 degrees of motion into the flexion or the elevation of the device. And so you can very clearly see we are able to visualize the decline in function at that limb. And again, this gives us a way to quantify what we see in clinic. That was a very small study, and we have been able to replicate these findings with the use of the ALS TDI data set, where participants are wearing the Actigraph watch for a week at a time each month and bilaterally. And this was under review when I submitted these slides, but it was just accepted and will be printed soon. So more to come on that. And then I wanted to spend some time talking about lessons that we've learned, because it's been kind of a painful process along the way, but we really do feel it's important to improve our outcome measures. So effective use of digital health technologies really does require manpower, and more than we expected. You cannot just set patients up, even with an app or a wearable watch, and expect everything to run perfectly. Technology doesn't work that way. And so you do need people monitoring the data and having frequent touch points with participants to make sure that you are getting the data that you expect and want to be collecting. Adherence matters. These are observational studies that patients are very willingly giving their time to help us improve our measurement. And the last thing we want to tell them is we couldn't use their data because they didn't wear it enough. So talking with them about what adherence we need to make the data meaningful. And I wanted to just show very quickly here a difference in the GPS versus, which is passive data, versus more active data, and then comparing, this is 3 different studies, but I'm just going to look at the first 2. The first is a 12-week observational study compared to a year-long, and the data completeness is along the y-axis there, and what you see is for shorter studies, our data completeness, especially in these observational studies, is going to be better, and really the GPS data, or that passive data, we have more data completeness, which probably plays into the participant burden. So with any of these, with all of the outcomes that we're collecting, there is participant burden, and we need to understand that. And I think Dr. Bedlack mentioned that we are collecting a lot of data, and we need to recognize that. That burden can mean different things for different patients. We've had some patients say just putting a device on reminds them that they are declining and that we are tracking every little thing, and that they didn't want to do that anymore, and so they dropped out. It also, sometimes just getting the device on or dealing with any of the technology issues can be quite burdensome. So keep that in mind and have open communication with the participants so we can try to improve things as we move this forward. An interdisciplinary team is key. We have a large team, well, I consider it large, but a team working on this from the beginning of study development, talking with patients and caregivers, our research coordinators who are carrying out these studies, the statisticians who will be looking at the data, and really it takes a team to figure out what data is meaningful and how we might use it moving forward. But it's really important to know what the purpose of your digital health technology is. Is it to identify symptoms, to track progression, to evaluate treatments? And if you don't have a clear understanding of what you're using it for, it's going to make it very difficult when you have all this data in front of you. You'll likely get lost in it. And then I thought I had an image here, but otherwise I did not, so it's kind of a boring slide, but considerations for digital health technologies. Cost is there, especially when you add a wearable, but also the manpower behind it. If you can use smartphones, that may help with cost savings. Think about wear time. How much do we actually need our participants to be doing? Where location? How does and then have a plan for your data transmission and data monitoring. For smartphones, there's a few more considerations. I'll just go down to the device usage. You want to make sure you know how your patient or participant is using their phone. If someone else is carrying their phone, you're collecting someone else's data. So we talk with our patients regularly to understand how and when their phone is with them. And then most importantly, participant engagement. As we are developing these new outcome measures, and if we plan to implement them into clinical trials and clinical practice, we need to understand when and how these might improve things for them and make their contributions and that participant burden worth it. So with that, I'd like to thank all of our participants and caregivers who have participated and continue to participate in all of our studies, our entire team at the Healy Center, especially Dr. Barry, who has led most of this work, and Sabrina Paganoni, who's my research mentor, and then many other collaborators and partners that have helped make this work and some of our other projects possible. No. Yeah, they keep turning it off on you.
It's not the technology, it's first. So energetic.
Okay. Oh, yay. I was just going to say, the technology is extraordinary. It was about less than 10 years ago when we did at our center, we did a trial with the Formula One driving company where they stuck a probe onto our chests for a week. And that basically only gave our heartbeat. At the time. And now we are all walking around with these mini computers that give so much information about everything we do. I can't even tell you if I slept well until I've looked at my app. So, has anybody got any questions for Catherine?
Great. Perfect.
You've stunned the audience. Oh, yes, we do have a question at the front here. May we have a mic?
Right in front.
Sorry, you're probably all getting tired of my voice. I'm David Busak, a patient fellow. So you had a few slides that had some large data sets showing generally consistent trends in a lot of the lines that we saw. Consistent downward, or I think consistent upward. But in each of them, there were one or two traces that were going in the other direction. So I was curious about that and what that tells us about those particular patients, or why we had those wayward lines.
That's a great question. So we've asked that question to ourselves a number of times, and actually in that recent paper that's coming out with the larger data set from ALS TDI, we see it again and in a larger group. And we haven't pulled them out to look at them yet, but it's definitely something that we want to look at. My initial thoughts for some of them were these people in the tofersen study. In a lot of these observational studies, we keep track of if they're in a clinical trial, but not which one. So getting more information about their treatments, whether it's a clinical trial, an EAP, or supplements that they're taking, I think would help answer some of those questions, but we haven't dug into them yet.
Good. Any more questions? No, I think that just leaves me to thank you, Catherine, for a very interesting speech. Thank you very much. Now, I'd like to introduce the next speakers to a really interesting presentation on racial disparities in the diagnosis and prognosis of ALS in patients living in the United States. And there's Jamie. Are there more of you? Just you.
Thank you. Thank you for the opportunity to speak today. I am Jamie Raymond. I'm the lead epidemiologist with the National ALS Registry. That's with the Centers for Disease Control in the United States. Today I'm going to be talking about our registry data and a recent study that we published on the racial disparities in the diagnosis as well as the prognosis of ALS. I have no disclosures. So I'll give a brief outline on what ALS is. I'm going to talk about the National ALS Registry and why it's important in this part. What do we currently know about ALS? And then I'm going to talk about our recent publication. So ALS, or Lou Gehrig's disease as it's called sometimes, is a progressive fatal disease that's caused by the degeneration of motor neurons. About 80% of our cases die within 2 to 5 years of their initial diagnosis. About 90% of our cases are sporadic, meaning just 10% have a familial or genetic background. The risk factors are largely unknown, especially for our sporadic cases. There's no cure. We do have 3 drugs that are currently approved in the United States that typically prolong life by about 2 to 3 months. So, in the early 2000s, there was a concerted push from ALS patients and caregivers to have an ALS registry in the United States. The public law was enacted in October of 2008. This directed CDC to create a nationwide US registry. The registry goals were to describe the incidence and prevalence of ALS in the United States. We wanted to describe the demographics of our ALS patients. And we wanted to examine the risk factors through risk factor surveys for ALS patients. 2 years after the law was enacted, we launched the National ALS Registry. Now, this act did not make ALS notifiable. So patients and caregivers, or patients and neurologists are not required to send cases to their local health departments or to CDC. And here is our website for more information. So why is the National ALS Registry important? Well, it's the first population-based ALS registry in the United States. We've been operating for just over 14 years. We do have a web portal portion, and in that, we started in 2010 with 6 risk factor surveys. We are now up to 18 risk factor surveys. So we have 115,000 completed surveys from our patients and over 20,000 patients who have voluntarily self-enrolled. We continue to seek what causes ALS through analyzing our risk factor surveys. We're looking at the causes, and we're trying to understand the incidence and prevalence as well as the mortality of ALS in the United States. So, unfortunately, we know a lot more unknowns about ALS than we know about ALS. Risk factors that we've identified in the registry as well as some of our partners. We know that white males over the age of 50 seem to have a higher rate of ALS than other demographics. Occupations. The University of Michigan has recently come out with some publications that showed that certain blue-collar occupations had a higher rate of ALS than others. Military service. We know that our veterans are about twice as likely to have ALS than our non-veterans. We published a couple years ago on leisure physical activity, and we did notice that those who exercise vigorously more than 3 times a week at younger ages were typically diagnosed at an earlier age. We've looked at smoking and drinking. as well as geography. Earlier this year, we published a prevalence report on all 50 states, and we did see a north to south gradient, with our northern states having a higher rate of ALS compared to our southern states. And then, of course, family history. So moving on, we took the survey data that we have, and we were able to look at some of the racial disparities in the diagnosis of ALS with our data. So we know that racial disparities are common and not just in ALS. This pertains not only to access to care, but to symptom onset to diagnosis, disease onset, and interventions that ALS patients receive. So we were able to analyze data from the voluntary patient portal, online surveys, for about a 10-year period. We were able to stratify race by white, black, and other races. And with that data, we've got a little over 4,000 ALS patients in our study. So the first thing we wanted to look at was age of diagnosis stratified by race. Now you can see here that for age of diagnosis, our black patients, we had about almost a little over a fourth of them were our white patients, that was just under 13%. We also saw something similar with almost a fifth of our other race patients being diagnosed before age 50, whereas you can see with our white patients, it wasn't until we hit about 60 that we saw that big jump of over 38%. So next, we wanted to look at mean time from symptom onset to diagnosis, again, stratified by race. And you can see here that our black patients had, from first sign of weakness until an ALS diagnosis, was about 24 months. For our white and other race patients, it was about 16 months. We didn't see, as far as cramps and twitches go, we didn't see much difference. We did see a difference in our problems with speech for our white patients. If they had problems with speech, they were likely to be diagnosed in a much shorter time frame than our black and other race patients. And then with problems with bowels, our other race patients tended to be diagnosed much faster than the white and black patients. So then we wanted to look at site of onset for our ALS patients. And we didn't see much difference, except we did see for hand or arm onset, our black patients were over 50%. More like percentage-wise to have that onset, as opposed to our white patients at just over a third. So then other symptoms that are common after an ALS diagnosis, we wanted to look at those as well. And I know this slide has a lot of data on it, but we did notice that pneumonia was a much higher percentage in our black patients compared to our white patients. And then we also saw a slight uptick with twitching in our other race patients compared to our white patients as well. So next we moved on to specific interventions that each of the races received. For wheelchair, our other race patients typically received wheelchairs later than the white and black patients. For non-invasive breathing equipment, our data was small for our other race patients, but most of them received it before they even had an ALS diagnosis. And then we also noticed that our black patients were more likely to be diagnosed or be referred to hospice sooner than the other races. So what were our findings? Well, we noticed that black patients were more likely to be diagnosed at a younger age, despite having a 2-year gap. And they were also more likely to have a higher percentage of having pneumonia. From first sign of weakness until the ALS diagnosis, it was about 24 months for our black patients, whereas that was significantly longer compared to our white patients at 16 months and other race patients at 15.8 months. We saw diagnostic delays. White patients had a shorter diagnostic delay of just at 6.3 months, and black patients were about 17.7 months. Other race came in at 14.8, And so racial disparities, especially in the diagnosis of ALS, continue to show diagnostic delays. Thank you.
So thank you so much for that. You've brought up a lot of really significant data. Do you have particular reasons or theories why there's such a discrepancy between diagnosis from 24 to 16 months?
So I think because our Black patients tended to be so much younger, I don't think neurologists or physicians were thinking ALS could be a possibility because they were diagnosed at a much younger age.
I think it's fascinating. I mean, really very significant. There are a lot of questions from the back.
Do you think that this would impact the ability to participate in clinical trials if their diagnosis is taking a lot or many months, I guess, more than a white patient, and the inclusion criteria in trials is?
I think it could. We don't do clinical trials, so I don't know exactly typically what the parameters are around it. But I would guess, I've heard that there are certain time frames. And so getting an accurate and quicker diagnosis would definitely help, I think.
Do you have any comparative data for Black patients from other countries, for example, in terms of the earlier age of onset in your study population in the U.S.?
That would be interesting. We have not, all of our data is from the United States, but I would be interested to look at other countries to see if their race breakdown is similar or as far as age of diagnosis. Absolutely.
Kathy Collett, ALS advocate from Indianapolis. When I read this paper, I was thinking, this is really interesting, but I think there are two ways to look at that age difference in the Black cohort.
Mm-hmm.
And one is, are they younger people getting ALS, or are the patients we're missing the oldies? Because you're missing, I mean, you don't have a representative complete picture there.
Correct, yes. This is 100% voluntary, yeah. So our cohort is typically in the web portal a little bit younger than probably the general population in ALS. So yes, that is definitely possible.
I think that's possible. Then another thing that kind of followed my thinking on that, and I would be very interested if anybody can do a study on this sometime, be very interesting, I think, to look at electronic health records and look at people who may have died before they got an ALS diagnosis. Because I think in that older group that may be at play. And I think that to look at the telltale signs of ALS in people who were never diagnosed and died could be interesting. Thank you.
Hi, thank you so much. Peggy Allred from Novartis. Really interesting work. And sort of keying on your comment, how much of the disparity do you think might be due to an accessibility issue for these online surveys, especially potentially in this older population, but really in the non-white population altogether, their access to the internet, their comfortability with entering these types of data, and how much that contributed to the numbers that we see?
Yes, it was definitely a limitation. You do have to have access to a computer in order to take these surveys, and it is voluntary. So there's no compensation or anything. So yes, we do know that is a limitation of our data. We did try and use as many years as we could. Like I said, in 2010, the first 6 surveys came out. This clinical onset survey didn't come out until 2013. So we really did try and use as many years as we could to try and get, but absolutely, it's definitely a limitation of our data.
Did I see? There's another question here.
Hi, thank you so much for the talk. I'm Isaac from Edinburgh. Just wanted to know that now that you have this data, what are your next steps, knowing that there is health inequalities in the States for Black male?
Yeah, that's a great question. We worked with a neurologist out of VCU on this manuscript because she was kind of seeing the same thing in her neck of the woods. So just trying to get it out there that ALS affects everybody. There is not one demographic that it does not impact. So knowing that hopefully will be in neurologists' heads, that even though if it's a younger person or a minority, that ALS is still a possibility.
I'm in the middle. Sunny from Texas with her ALS story. And just a comment from personal use, I think what you may be, not you, but the study made me missing is that your website is awful and the app isn't user-friendly and it's not eye gaze technology friendly. So even being almost 10 years in, I willingly opted not to participate because it's not configured to use on my phone. So if it's not easy or it doesn't come with a beer, I'm not doing it.
So I will say, I don't know if it's good or bad, our website has changed significantly, like I think this week or last week. It is in line with what CDC does. So we're limited in how we can display the data. We are trying to make the surveys more user-friendly on an app, but we have to be careful because when people register, they're registering their names, and that goes in a secure database that you can't use an app to do that. So we are trying to make it more user-friendly and to make it look visually appealing. But it takes time because, like we said, we have 18 surveys. But yes, check out the new website. Let us know if you like it better or not. We can only change so much of it because we're kind of constricted. But check it out and let us know.
Oh, there's another question there.
Sonny, not an inducement, but I'm happy to sit alongside you, and you might have some sips of my beer if you finish this. So thank you, Janie, for presenting, and I'm Lauren with Les Turner. We are a contracted provider. And, you know, taking a look at the needs and as reaching out into the community is something that we have to do better, and we take ownership of that at Les Turner. But one of the things that I think I wanted this global audience to know is there was a National Academy of Science, Engineering, and Medicine report that very clearly used some of the data that Janie presented and outlined ways for us to meet the challenge of health equity. And so we all have a responsibility in the States and across the globe, because I keep thinking about the health disparities across the globe, but then I also think about the health disparities in our neighborhoods. So thank you for presenting this data today, and I look forward to talking more with our colleagues about what are you doing. So I want to learn more from everyone. So I'll buy you a beer too, if you have a good story to tell.
Thank you. I think that's a lot of questions. Is that all the questions now? Lovely. Well, thank you, Catherine, for your presentation. And now I'd like to move on to an evaluation of the United Kingdom motor neuron disease nurses and allied health professionals workforce census. Do you know what? That acronym is like alphabet spaghetti. I'm not even going to attempt it. But Isaac, would you like to come and present your talk, please?
Hello, everyone. My name is, I think I'm too tall for this. Hello, everyone. My name is Isaac. I'm a research nurse from the Anne Rowling Clinic in Edinburgh, and today I'll be discussing a cross-sectional analysis that my colleagues and I did to evaluate the MND nursing and allied health professionals workforce. where we've generated themes and discussions based on the evaluation. As many of you already know, MND is a fatal and devastating disease, but what I would like to highlight for all of you today is that it requires an extensive multidisciplinary team to fully support our patients with MND. This is also one of the recommendations from the National Institute for Health and Care, the NICE guidelines that underpins how we deliver effective and supportive MND care from our healthcare professionals. And from this, we know that the MDT is an essential component to delivering effective MND care. So this begs the question, how is the MDT doing? And within the scope of my practice and my remit, how are the nurses and the allied health professionals doing? Therefore, we recognize the importance of evaluating this workforce, and in particular, the nursing and allied health professionals team, where it is mostly unknown within the literature. Within the literature, there is a vast gap in the knowledge of the workforce itself, whether it is the knowledge of the demographics of the workforce, the compliance with national frameworks and standards, and the experiences and well-being of the workforce itself. And we hope that we could shed some light with our research. Therefore, there was a unique opportunity that arose in the inaugural UK MND NAHP gathering in November 2023 that was held in Edinburgh. This was a first known meeting among all the MND workforce that invited all the nurses, all the care coordinators, occupational therapists, physiotherapists, research nurses, and other allied health professionals, such as dietitians and respiratory services from across the UK, with individuals coming all the way from the Shetland Islands to the Isle of Man. From this, we wanted to make use of this rare and unique opportunity by coming up with some of the aims to explore this workforce. This includes, what is the size of the workforce? Are they complying with national frameworks and standards? And what are their experiences and how is their well-being? And we hope that we could link these to some demographic factors as well. And so to meet the aims of the study, we employed a pragmatic approach which allowed us to be more flexible in our methodology, and we made use of the convergent mixed methods approach. This means that after collecting the quantitative and the qualitative data, we were able to analyze and collate both the data sets together to create broader themes and sub-themes. This data was collected through a cross-sectional census, online or paper questionnaire survey, as you can see on the left. Demographic data and work-related characteristics were collected. General compliance with the NICE guidelines and the MND nurse competency framework was assessed through multiple choice questions, and Likert scales and free text boxes were used to assess satisfaction and the feelings of being valued. The burnout assessment tool, core and secondary, also called the BAT-C and the BAT-S, is an externally validated and reliable test that uses several questions to assess different aspects of burnout. It makes use of a traffic light system to determine different risk of burnout, as you can see on the right. The quantitative data was analyzed using the statistical software R, where we use chi-square tests and one-way ANOVA tests for continuous data sets, and the qualitative data was analyzed using the content analysis framework, and we used the NVivo 14 qualitative software to organize our themes and sub-themes. And so overall, we obtained 64 responses, which was 75% of the 80+ attendees of the meeting. And so this data may not be representative or generalizable. However, there are much themes and results that I would like to highlight. When assessing the demographics data, we can see that the respondents were mainly from Scotland and England, female, white British, and 41 years or older. Looking further at the demographics data, there are some interesting points that I'd like to highlight. The first in which it is a highly qualified workforce, which we can see 70% of the respondents have obtained a bachelor's degree or higher, which is reflected in a large number of respondents being in a senior level member of staff. While this represents a highly qualified workforce, almost 50% of them are not working full-time. Looking into the employment demographics, we can see in the first table, there are fluctuations in the number of months worked in MND care, number of patients in their caseload, and the time in their current posts. And this is based on the high standard deviation in the 3 columns. This can be actually considered quite positive because it reflects a good balance between those more experienced members of staff and those who are more junior and those who have just started out in their role. I also want to point out that 30% of the respondents highlighted vacancies within their core MDT, which I will link to the themes that we've generated later on. And so the first theme that was generated is the benefits of the multidisciplinary team. When we first got involved looking into the qualitative data, one of the initial and the most prominent themes was how a supportive and extensive multidisciplinary team is imperative and essential for almost every respondent, as we can see in some of the quotations in the slide. We can see a high percentage of respondents have an established relationship with many members of the core MDT, and this aligns with the NICE guidelines, and we can see this shows a high level of support for the UK MND NAHP workforce. Furthermore, more than 80% of the clinical professionals reported a relationship with respiratory services, gastroenterology services, wheelchair services, and assistive technology services, which are crucial relationships to aid in supporting our patients. This is important to note because this does align with the NICE guidelines, where it stipulates that the multidisciplinary team should have established relationships with the following services. However, on the flip side, there is a notion where when there are vacancies and limitations within the core MDT, it affects negatively for the healthcare professionals itself and also the patients. As we can see in one of the quotations written in the slide, there is a knock-on effect when teams are short-staffed. Furthermore, we identified a lack of established relationships with services such as counseling and neuropsychology from both the quantitative and the qualitative data. And this relates to what was previously mentioned, where 30% of the respondents are reporting vacancies within their core MDT. Relating this to the wider literature, many researchers have highlighted the benefits of the MDT and how imperative some of the specialties, such as the palliative care specialists, are to ensure patient-centered care and optimal health benefits for our patients. The second theme that we've developed is the notion of roles and responsibilities. Again, overall, the qualitative data shows that most of the respondents are very happy about their job. Specifically, when looking at the clinical professionals, many respondents reported benefits of the job such as flexibility, autonomy, and developing a wide range of competencies in such a challenging and evolving environment. This may relate to the notion of seeing high percentage of attainment in competencies surrounding provision of information and expertise, acting as an advocate for the patient and their family, and leading and collaborating within the MDT. However, reading down the table on the right, we can see that there are some competencies that have low engagement. For example, competencies such as muscle management, respiratory analysis, and specialist medication management, which includes the use of Botox.
This links with the qualitative data where the respondents mentioned the potential issue of a nebulous definition of what the MND service can provide, and this can cause some differences in expectations from our patients, as you can see in the quotation on the bottom left. Some other members of staff may not know the full remit of what the healthcare professional's job is, and this can cause the patients to expect more than what the service can provide. And lastly, I'd like to point out that there may be geographical differences between the job roles, and this can cause inequitable care and issues within delivering the care. The final theme that we've developed is benefits and challenges in providing direct care. In this theme, we can see impressively high satisfaction and valuation scores shown in the table, where 100% of the respondents felt often or always valued by patients and their families. And a high proportion of respondents said that they felt valued by other healthcare professionals within and outside the MDT. Extending this discussion into the burnout scores, again, we see an impressively high rate of low risk of burnout, with 78% of respondents are at low risk of burnout. This can be related to the qualitative data, where some of the respondents expressed sincere gratitude for the individuals that they were taking care of. While the work may be perceived as challenging, the respondents felt content with their job role, and they received much satisfaction from their work. However, by further breaking down this data, we can see that a higher percentage of non-clinical healthcare professionals had a lower risk of burnout than their clinical colleagues, which is what you would expect. However, looking into the data, there are still 14% of overall respondents who are at risk of burnout, and 6% of them have already burned out. Furthermore, 8% of the clinical colleagues are more likely to have already burned out. Looking more closely with the total BAT scores, the exhaustion subsection of the burnout questionnaire showed that almost 25 of the respondents were identified as a medium to high risk of burnout that has similar rates seen in the emotional and cognitive impairment subsections, which highlights some nuances in the data. For example, when we further consulted some of the respondents, they have suggested that there may be some limitations to our cross-sectional methodology, where if this was asked to them in another day, their questions and their responses may be different, and you could see the results being worse, and this highlights a need for further assessment and review. This links with some of the identified challenges in providing direct care as described in the qualitative data. This refers to some of the respondents saying that there may be organizational barriers. Some of them actually commented that they are facing some funding difficulty and a lack of resources, meaning that there is a mismatch between what the patients need and what they could provide. Furthermore, some of the respondents also commented on feeling isolated, where they were where many of the respondents are lone working. When linking this to the wider literature, we can see similar issues where organizational barriers and burnout can negatively impact patients. Where there are some limitations to our report, given the small sample size and the potential for bias, there are large amounts of implication. There is a need for a national standardized competency and job definitions that can be achieved through education and policy. Further resources are needed to address the issues with compliance to national frameworks and identify organizational barriers to reduce the issues of inequitable care. And further research should be performed to offer longitudinal assessment and consultation with the workforce, and to better understand the demographics, compliance, and mental well-being of the workforce. This may offer a unique opportunity to maintain a resilient and effective workforce. And to assist in these implications, we are currently working with the University of Edinburgh to develop a master's level course, and we are currently formulating a dissemination plan to submit this into a research journal and to attend conferences and to disseminate our lay brochure, which you can use the QR code to view the brochure. So in conclusion, I would like to say that the census has provided novel and valuable insights into our workforce. We have developed themes such as the benefits of the MDT, the roles and responsibilities, and the benefits and challenges in providing direct care. While there are some limitations, we have addressed that there is a need for education and policy change and to address any organizational barriers. I would like to thank the UK MND NAHPs for contributing to this finding. I'd like to thank the 4 charities for funding the inaugural gathering. And I'd like to thank the Ann Rowling Clinic for funding this important work. Thank you.
Thank you, Isaac, for that. It's a really fascinating presentation. I can see lots of hands here. Jess.
So I've got a question from Sue Nelms from MNDA in the virtual room, and she's asking, what actions should be taken to protect MND nurses from burnout? Relationships are important, but that will also impact on the well-being of nurses.
That's a really good question. So during that meeting, when that question was brought up, a lot of ideas were being shared by the nurses themselves, actually. And I think some of you in the audience right now were there in that meeting. But a couple of things were brought up, just developing preventative burnout strategies. You want to be not reactive, but proactive in how we can maintain a resilient workforce. So looking into the organizational barriers within different health boards in the UK are very important, and addressing that with the senior management team is very important as well.
I have a question for you, Isaac. You concentrate a lot on burnout. Now, I associate burnout with the systemic environmental pressures, like lack of time, lack of equipment, and things like that. What really affects, I think, healthcare professionals is compassion fatigue. Is that something you thought about or looked at kind of measuring in any way?
Was it compassion?
When fatigue, when you give, and then you can't give any more, and you get little back. Nurses and healthcare professionals suffer a lot from compassion fatigue, I think.
Yeah, that is extremely important. I think one of the senior research nurses in Edinburgh, her master's was on compassionate care for the healthcare professionals. We can definitely disseminate this with her and look into how we can provide that for starting with the nurses in Scotland, and then we can disseminate that to the rest of the UK.
Okay, thank you. Are there any other questions here? Okay. Isaac, I'd like to thank you very much for your presentation. So we draw this amazing day to a close now. I have a few announcements for you. Well, I clearly didn't get the memo. Today is a lilac purple day. Nobody told me. So anybody wearing lilac and purple, or any color or shade in between, they'd like to have a photograph here when you're ready. We are now, if you'd like to go to the foyer to have drinks and a reception there, followed by going to the East Ballroom, where there will be the Family Feud competition or a game at 6 o'clock. We'd like to welcome you back here tomorrow at 9 o'clock, and we hope you've had a very interesting and enjoyable day. All the sessions from today have been recorded and will be available after the event for you to view at your leisure. So thank you so much for joining us, and I hope you had a good day, and please enjoy the reception outside.